Hi, good afternoon. Welcome to today's webinar entitled Updates in Diabetes Care, presented by Unbound Medicine and Johns Hopkins. And how appropriate to have this webinar on World Diabetes Day, raising awareness for this disease. Please let me give you some background on our presenter. Dr. Rita Kalyani is an associate professor at the Johns Hopkins University School of Medicine, and she's an active clinician scientist focused on the development of diabetes complications, particularly in high-risk populations. Dr. Kalyani is a past chair of the American Diabetes Association's Professional Practice Committee, which is responsible for the annual clinical guidelines position statement, ADA Standards of Medical Care in Diabetes. She is the co-founder and editor-in-chief of the Johns Hopkins Diabetes Pocket Guide. Now, just a few things about the webinar itself. The first part is pre-recorded. Following the presentation, Dr. Kalyani will be hosting a live Q&A session. So please put any questions you have in the chat or in the question and answer window. And thank you for attending. We know your time is valuable, and we appreciate you spending the next 45 minutes or so with us. Take it away.
Thanks so much, Brian. I'm happy to be here. Today, I will be talking about recent updates in diabetes care. I'll first start off by giving a brief background on diabetes. We know that diabetes is a global epidemic. It affects people of all countries, all races, men and women equally. And according to the International Diabetes Federation Atlas, which came out last year, there are 537 million adults who are living with diabetes all around the world. This number is projected to rise exponentially to 783 million by 2045, and 3/4 of adults live in low and middle income countries. So this is truly a global disease. We know that diabetes is a leading cause of early mortality, and perhaps even more concerning is that 541 million adults are at high risk of developing type 2 diabetes. They have prediabetes, and without early intervention efforts will go on to develop diabetes. Diabetes develops over many years, and this is a slide that shows the natural history of the disease. You can see here looking at the 0 mark where people are diagnosed with diabetes, that really the process starts up to a decade earlier. You can see that insulin resistance, as indicated in the blue line, increases progressively beginning a decade before diagnosis. The body tries to compensate by producing more insulin from the beta cells, as reflected in the red line. And you can see for that sometime the body is able to maintain normal glucose levels as shown in the yellow and orange lines. But by about the 5-year mark before diagnosis, blood sugar levels do start to rise, and that's what we call prediabetes. Without intervention, insulin resistance progresses. The beta cells are no longer able to compensate by producing more insulin. And in fact, they burn out, as you can see, with the relative function declining in the red line. And as a result, fasting and post-meal glucose levels start to rise, leading to the diagnosis of diabetes. There are 2 major forms of diabetes, type 1 and type 2. Type 1 diabetes accounts for up to 5% of diabetes around the world. It is due to autoimmune destruction of the beta cells, the cells that produce insulin in the pancreas, usually leading to absolute insulin deficiency on diagnosis. People need insulin from diagnosis. Type 2 diabetes accounts for the vast majority of diabetes in the world, 90 to 95%. This tends to be linked to family history, for instance, in obesity, and it is due to a progressive loss of insulin secretion from the beta cells, usually in the background of insulin resistance, as I described in the previous slide. Another form of diabetes that's important to mention is gestational diabetes, which affects women who are diagnosed with diabetes for the first time during the 2nd or 3rd trimester of pregnancy and didn't have diabetes before. Often this resolves when the baby is delivered. However, these women are at a 50% increased risk of developing type 2 diabetes in their lifetime and need continued screening. There's also several less common types of diabetes that are due to secondary causes such as pancreatitis or HIV, and then also genetic causes such as maturity onset diabetes of the young, which has also been reported. Diabetes can also be secondary to glucocorticoid or steroid use and can also be seen after organ transplantation. The criteria to diagnose diabetes, however, is the same regardless of the type. And these are the criteria for screening people with diabetes or prediabetes. Those people who have a body mass index greater than 25. For the general population, or greater than 23 for Asian Americans, this is considered being overweight. They would be considered for screening if they have an additional risk factor, such as having a first degree relative, such as a parent with diabetes, belonging to a high risk race or ethnicity, such as African American, Hispanic, or Asian American or Pacific Islander. If they have previous metabolic diseases as listed there, women with a history of gestational diabetes or polycystic ovarian syndrome would also be considered at higher risk. Anyone who has a history of prediabetes should also be screened annually for diabetes. And for all other patients who don't necessarily have the risk factors noticed above, they should initially have a screen at the age of 35 to ensure there is no prediabetes or diabetes. And then if results are normal, they can be repeated every 3 years. But if they're prediabetes, it should be repeated every year to make sure diabetes does not develop. These are the criteria for the diagnosis of diabetes. You can see that there are 3 different criteria that can be used: fasting glucose, 2-hour glucose, and A1C. Fasting glucose requires the patient to be without food or drink for 8 to 10 hours prior to the test. The 2-hour glucose is usually after ingesting a 75-gram glucose solution containing 75 grams of carbohydrates. And the hemoglobin A1C level can be done whether the patient is fasting or non-fasting. There's various criteria as listed there for the diagnosis of diabetes, also for prediabetes, and then the normal level for fasting glucose would be less than 100, for the 2-hour glucose less than 140, and the A1C would be less than 5.7%. Sometimes the results are discordant. Someone may be positive on one criteria but not the other, and you only need one for diagnosis, but it does need to be confirmed on a subsequent test. The current approach to managing diabetes is multi-pronged. It includes supporting the patient with self-management strategies at home. Diabetes is a self-management disease that requires the patient to check their glucoses, to monitor their diet, to monitor their activity, to take their medications all at home. And so education is a key component. Diabetes technology has undergone dramatic transformation over the past few years, and I'll talk a little bit about that. And lifestyle changes through diet and exercise and weight loss are key at all points in prediabetes to diabetes progression in order to reduce insulin resistance and maximize the benefits of diabetes therapy. In addition to hemoglobin A1C or glucose lowering, we focus on blood pressure management, cholesterol management, and then also smoking cessation and obesity management, and then antiplatelet therapy as indicated. I will not be talking about those features today, what we call the cardiovascular prevention profile, but we will be focusing on the newer therapies with cardiovascular benefit and also talking about some of the newer technologies that we have too. In terms of patient goals, we usually focus on individualizing patient goals. A reasonable A1C goal for most patients who are not pregnant is less than 7%. This is by the American Diabetes Association recommendations. A more stringent A1C goal, such as less than 6.5%, may be appropriate for some patients, such as those who are younger, who have shorter duration of diabetes and don't have any higher risk of hypoglycemia and have a longer life expectancy. Less stringent A1C goals, such as less than 8%, on the other hand, may be appropriate for those for whom it may be more challenging to attain a strict glycemic target, such as those with a history of severe hypoglycemia, those who have limited life expectancy, those who already have established complications such as retinopathy, nephropathy, or cardiovascular disease. We also tend to be less aggressive about goals since our goals change. And those with long-standing diabetes or extensive comorbid conditions, we may also relax A1C goals as well for these patients. But again, it is individualized to the patient. We are at a time which is very exciting in diabetes care, and we have seen a dramatic explosion in the number of classes of therapies that we have for diabetes. You can see the evolving landscape in the United States of therapies that are available. This is likely similar in many countries, but this reflects the FDA indications here in the United States. You can see that insulin was first discovered in 1921. We did have biguanide fenformin that was on the market for some time in the 1950s, but was removed due to severe risk of lactic acidosis. But then we had metformin, which was introduced and approved in the 1990s in the United States, which continues on the market and has been found to be very safe in terms of the risk of lactic acidosis. We've also had second and third generation sulfonylureas, such as glipizide and glyburide, that have been around since the 1980s. Alpha glucosidase inhibitors, such as acarbose, the meglitinides, such as repaglinide and nataglinide as well. You can see were approved in the 1990s. The thiazolidinediones. So we initially had triglycerin that was approved, but that was taken off the market due to risk of severe liver failure. But we continue to have pioglitazone and rosiglitazone that are currently on the market. And then GLP-1 receptor agonists, DPP-4 inhibitors, and the SGLT2 inhibitors have been perhaps some of the most exciting classes that have been on the market really over the past 2 decades. And I'll be going into greater detail about those shortly. Again, these are the different drug classes that I mentioned. Those are the specific medications that are in those drug classes that you might be familiar with. And then the A1C lowering benefit, as you can see, ranges anywhere from really 0.5% to up to 2% for the biguanides, the sulfonylureas, and also the GLP-1 receptor agonists can be up to 1.5%, as can the thiazolidinediones. So glucose lowering efficacy is also a consideration in choosing which drug to use for your patient. Insulins in general have no theoretical limit on how much they can lower A1C. It depends on the dose and what the patient can tolerate in terms of risk of hypoglycemia. The oral agents for type 2 diabetes have multiple sites of action. This figure shows that the sulfonylureas are insulin secretagogues. They help the pancreas secrete more insulin to overcome that insulin resistance that we talked about. Metformin, on the other hand, is a hepatic insulin sensitizer. It makes the liver more sensitive to insulin, which then suppresses inappropriate hepatic glucose production, which is usually one of the earliest manifestations of fasting hyperglycemia. We also see that the thiazolidinediones, rosiglitazone, and pioglitazone are really the only class that directly impact the primary mechanism in type 2 diabetes, which is peripheral insulin resistance, by improving sensitivity of the muscle and improving insulin-mediated glucose uptake, particularly after meals. And then the alpha glucosidase inhibitors, acarbose and meglitol, they affect carbohydrate metabolism in the gut, prevent carbohydrates from being absorbed, but do have GI side effects, which limits their use. Now, turning to some of the newer classes, we have began to increasingly recognize incretins are hormones secreted by the gut in response to food in the gut. And what these hormones do, GIP and GLP-1, is they have multiple sites of action. They enhance glucose-dependent insulin secretion as their primary mechanism that we'll talk about, but they also have effects on gastric emptying, glucagon secretion as well, and then they also can promote satiety and reduction of appetite. So the two main incretins are GLP-1 and GIP that are secreted again by the gut when we eat. These then are converted to an active form, and it's this active form that is responsible for all the effects that I just mentioned. These hormones are degraded by the DPP-4 enzyme, and that makes these hormones then inactive. So you can see that the DPP-4 inhibitor class of medications basically inhibits the enzyme here. So it promotes endogenous levels of the incretins, whereas the GLP-1 receptor agonists, which is another class of medications, are synthetic versions of the hormone that's naturally produced. And this class of hormones, the incretins, were first discovered from this Gila lizard that you see here, and has now been synthetically available as the GLP-1 receptor agonist class. You can see all the different medications and their brand names that are currently available here in the United States. They're injectable versions, and there is one oral version known as semaglutide or Rybelsus. And then you see the DPP-4 inhibitors, which are all oral medications. And again, you can see all the medications listed there with their brand names. The SGLT2 inhibitors is also the newest class of medications that have been currently available in the United States. They were first approved in 2013. You can see the list of medications there and their brand names, and they work through an entirely different mechanism by blocking reabsorption of glucose in the proximal tubules of the kidney. So they don't affect insulin secretion really at all, but they do have side effects such as genital infections, urinary tract infections, as might be expected. And there's also other adverse effects that have been reported, something we call euglycemic diabetic ketoacidosis, especially when it's used in patients who might not have a lot of endogenous insulin secretion. And then there are warnings for fracture and amputation in some specific agents in this class as well. So this is a class that we'll talk more about and is an exciting new class because of its mechanism of action too. Now, in terms of insulin, we will talk about the injectable insulins that are available, but I did want to just briefly mention inhaled insulin. We have one on the market, Afrezza, which is given as a mealtime insulin. It doesn't replace the basal insulin, but it's not to be used in those with a history of lung disease or smokers, and it does have some pulmonary side effects as listed there. It is an option that is available for some patients depending on their individual preference. There's also other drugs approved for the treatment of diabetes that were found to have benefits for glucose lowering, although they were initially approved for other conditions. So bromocriptine is used for hyperprolactinemia, but the short-acting version of that has been found to have benefits on glucose and is also approved for diabetes. And then colesevelam is a bile acid sequestrant approved for hyperlipidemia, but also has benefits on glucose, and so is additionally approved for type 2 diabetes. So we now have many different agents that act through many different organ systems to impact blood glucose levels. You can see all the different organ systems that we now can target through the different therapies that we have. And this is a very exciting time for us with having so many tools to offer patients. Now, I'm going to focus primarily on some of the newer therapies because there's been a lot of developments in terms of the cardiovascular outcome trials that have come out, the evidence, and then what conditions, comorbidities they can be used for. So just as some brief background, these were due to guidance from the FDA in 2008 that mandated that all newly approved drugs for diabetes had to have a post-marketing cardiovascular outcome trial. And this was due to some concerns about safety of the older drugs that were on the market. And so since that time, any new drug approved for diabetes has to have a cardiovascular outcome trial to demonstrate safety against placebo of any newer drug for cardiovascular events. There are certain criteria that have to be met, as you can see here, for these cardiovascular outcome trials. And again, the FDA notes in this guidance that sponsors should demonstrate that the therapy will not result in an unacceptable increased risk of cardiovascular events. Now, interestingly, what's been found since 2008, we now have over 100,000 participants that have participated in cardiovascular outcome trials for all the SGLT2 inhibitors on the market, almost all of the GLP-1 receptor agonists on the market, and almost all of the DPP-4 inhibitor agents on the market too. And what we have found is that all of them are essentially safe in terms of not increasing risk of cardiovascular disease, but a few of them actually are superior to placebo. They actually have benefits in reducing cardiovascular events. And so this has led to a monumental shift in the medications that we have. We now, for the first time, have agents that not only lower blood glucose, but also have additional benefits in reducing the risk of heart disease in those who already have a history of heart disease. So these are the official FDA indications for the various SGLT2 inhibitors we have on the market and the GLP-1 receptor agonists, where we have specific agents that have been found to have cardiovascular benefit. So empagliflozin, or Jardiance, has an FDA indication in addition to its glucose lowering benefit to reduce the risk of cardiovascular death in those with type 2 diabetes and a history of cardiovascular disease, and also to reduce cardiovascular death and heart failure hospitalization in those with a history of heart failure. Canagliflozin, or Invokana, has an FDA indication to reduce the risk of major adverse cardiovascular events in those with a history of type 2 diabetes and established cardiovascular disease as well. And that dapagliflozin, or Farxiga, has an indication to reduce the risk of heart failure hospitalization in those with type 2 diabetes and a history of cardiovascular disease, or those who are at high risk, those who have multiple cardiovascular risk factors, so as primary prevention as well. And also it has an indication to reduce heart failure hospitalization in those with reduced ejection fraction. For the GLP-1 receptor agonists, liraglutide or Victoza has an FDA indication to reduce the risk of major adverse cardiovascular events in those with type 2 diabetes and established cardiovascular disease. Ozempic, the injectable version of semaglutide, has an FDA indication to reduce the risk for major adverse cardiovascular events, again, in those with type 2 diabetes and known cardiovascular disease. And then dulaglutide or Trulicity, also, in addition to its benefits in reducing major adverse cardiovascular events in those who have type 2 diabetes and established cardiovascular disease, was also found to have benefits in those who have multiple cardiovascular risk factors, so as primary prevention. So as you can see, there are multiple agents in each of these classes with different indications for their cardiovascular benefits or heart failure benefits, primarily based on the trials in which these were studied, that are now available for us to incorporate into our algorithm for diabetes care. So this is the most recent algorithm from the American Diabetes Association Standards of Medical Care in Diabetes from 2022. And what you can see is that in general, first-line therapy has traditionally almost been metformin, and it is still generally recommended that for most patients, metformin should be first line, in addition to lifestyle treatment and also cardiovascular disease risk prevention. But for those who have a history of atherosclerotic cardiovascular disease in that left panel there with the red heading, or who are at high risk for cardiovascular disease or have a history of heart failure, the agent that we choose next, or in addition to metformin, will now depend on whether they have one of these conditions, because if they do, we preferentially want to choose one of those agents in the GLP-1 receptor agonist class or SGLT2 inhibitor classes that have cardiovascular benefits. So if they have a history of atherosclerotic cardiovascular disease or have high risk, that's the very left column, you want to choose a GLP-1 receptor agonist or an SGLT2 inhibitor with demonstrated cardiovascular benefit. If they have heart failure, so that's that middle, the second column that says heart failure there, the SGLT2 inhibitors that I mentioned have additional benefits on heart failure, reducing heart failure hospitalization, and so they would be preferentially indicated. And we didn't talk about chronic kidney disease, so I'll just mention it in passing, but some of these agents also have benefits on chronic kidney disease progression, specifically the SGLT2 inhibitors, and so those would be preferentially indicated for those patients. On the right part of the algorithm are all the people that don't have any of these comorbidities. So no history of cardiovascular disease, heart failure, or chronic kidney disease. That's when we choose from the very many number of classes that I previously mentioned. And factors that you might think about include whether you need to minimize risk of hypoglycemia, whether you want to minimize weight gain, and also cost and access. And so for patients who don't have the comorbidities, that's when you really would choose based on individual factors. This is another table from the ADA Standards of Care, which goes through A1C efficacy, hypoglycemia, weight changes, cardiovascular effects, cost, route of administration, oral or subcutaneous, and renal effects, and then black box warnings or adverse effects that you might consider in choosing any one of these classes that we talked about. And so as you can see, it's really individualized care, and the choice of agent really depends now not only on A1C lowering efficacy, but also the presence of these comorbidities. The cardiovascular comorbidity in particular, we would add on one of these agents with cardiovascular benefits, even if someone's at their A1C target, in order to reduce the risk of cardiovascular events in the future, although we may have to titrate some of the background therapy to prevent hypoglycemia. So this is really a monumental change in the way that we approach diabetes. We have two goals: A1C lowering and also the reduction of cardiovascular and heart failure comorbidities. So just briefly, I'll talk about insulin, because insulin has been the first therapy since 1921 on the market, and we've seen lots of advances. It's the oldest therapy available. We had the greatest clinical experience is the most effective. It will always lower A1C since it's a synthetic version of the hormone produced by the pancreas, and there's theoretically no maximal dose that you can go to. The only limitation really is the volume of injection, and we now have concentrated insulins that can limit that volume. And it can be used in combination with oral agents and also GLP-1 receptor agonists, the non-insulin injectables as well. So it can be really used with any of the therapies I talked about. As we talked about, it was discovered more than 100 years ago. The first rapid-acting analog insulin, insulin Lispro, was approved in 1996. The first long-acting analog insulin, insulin glargine, was approved in 2000, and the first insulin pen device was approved in 1985. These are all the different insulins that we currently have on the market up to 2015, and I'll show you those since that time in the next slide, and then their drug brand names as well. And on the second slide, I'm going to focus on biosimilar insulin, biosimilar glargine, and talk a little bit more about what that is. It was first approved in 2015. We'll also talk about biosimilar and interchangeable glargine, first approved in 2021, known as Semglee. So insulins are not considered generic products because that term is really reserved for copies of non-biologics, the small molecule drugs that contain the exact same active ingredient as the respective proprietary reference drugs. But insulin is a large protein biological product, and it requires greater complexity in manufacturing. So the term we use is biosimilar insulins. They're manufactured in living organisms to produce large quantities of the drug. And this limits the ability to manufacture exact replicas of the original biological medication, but it's pretty close. So biologics such as insulin are therapeutic products composed of sugars, proteins, nucleic acids, cells, or tissues. The reference product is the first biologic. In this case, it would be insulin glargine or Lantus, against which future biologics are evaluated. Biosimilars are highly similar biologics to a reference product. Again, they're not exactly the same because of what I described before, but they have no clinically meaningful difference in purity, potency, or safety. And then interchangeable and biosimilar insulins are biologics that meet the requirements of biosimilars with the same clinical results as the originator, but the risk of reduced efficacy or increased adverse events from switching to this biosimilar is no greater than the risk of continuing with the original originator. And because that risk is so low, you can freely interchange. The pharmacist can freely substitute this interchangeable insulin for the brand name when the prescriber writes for it. So the prescriber may write for the brand name insulin glargine, Lantus, and the pharmacist can now interchange the biosimilar interchangeable product known as Semglee without necessarily having to contact the provider, although we'll talk about how many pharmacists still do contact the providers. This is the molecular form of Basaglar, which is a biosimilar glargine, to Lantus, which is the brand name glargine. And there's just a few changes in the position A21. And then there's also 2 arginines added to the C terminus of the beta chain. So those are the only differences between the biosimilar Basaglar and the originator product, brand name Lantus. So the reason to use biosimilar insulins is that there's a cost benefit, and there have been many studies that have demonstrated a cost benefit for these insulins, and this is part of the reason why they've gained tremendous favor since their initial introduction in 2015. Interchangeable insulins, like I mentioned, legally pharmacists can automatically substitute the brand name drug with the respectable biosimilar interchangeable product without having to contact the prescriber, although in practice, many do still contact the provider just to let them know. And the current interchangeable insulin that we have on the market is the unbranded version of Semglee. It's available by prescription in either a pen or a vial, and is more than 50% discounted in cost from the list price of Lantus. Actual out-of-pocket costs for biosimilar insulins can differ because the list price does not consider discounts or rebates that are available for a variety of branded insulin brands too. So you really have to look at the cost to the patient. But in general, biosimilars and interchangeable insulins are cost-effective. This is a summary of all the different insulin preparations currently available. You can see that they have different onsets of action and different durations. We have those that act rapidly and only last for a few hours. They tend to be used for meals. We have intermediate and long-acting insulins that can act at anywhere up to 8 to 24 hours or longer. And they tend to be what we call our basal insulins that are given to maintain glucose levels within range and even between meals. And then we have the premixed insulins, which are not used as commonly, but can be considered for patients for whom cost may be a consideration. NPH regular premix tends to be less expensive than some of the other basal insulins, analog basal insulins, or for whom reduced injection frequency is a consideration. We also have Humalox mix and Novolog mixes available as well. And this is a figure showing the different onset of actions of these different classes of insulins and then how long that they last. And you can see that they last all the way up to 24 hours for Degludec, which is an ultra long acting insulin, and the rapid and ultra rapid acting insulins, even that we now have on the market, really can have an onset within half an hour to an hour. Now, moving to diabetes technology, this has really transformed the day-to-day management of the disease for patients. It's really facilitated, I think, greater control over glucose management and quality of life as well. We have the real-time continuous glucose monitor, which is a device that patients can wear. There's a catheter that goes under the skin and measures glucose in the interstitial fluid, and it gives a real-time display of glucose on an external palm-held device or insulin pump, which I'll share with you next slide. As I mentioned, the sensor is inserted under the skin and has to be replaced every few days, and it may be useful for patients who have hypoglycemia unawareness because it does have alarms that can go off when the glucose level is too low, or for those who have widely fluctuating blood glucose levels to understand patterns, particularly at night, because it can awake people at night. And alarms can be set, as I mentioned, for extremely high or low glucose levels. So this is an example of a real-time continuous glucose monitor. You can see on the top right-hand corner the glucose number. Below that, you can see the arrow, which tells the patient if the glucose is trending up or down, which can be really helpful. You can see the graph of their glucose levels over the past few hours. And these levels are updated every 5 minutes. So patients can see in real time how their glucose levels are doing. We also have, in addition to the real-time continuous glucose monitors, we have a different type of continuous glucose monitor called intermittent or flash or on-demand continuous glucose monitor. This is a sensor often worn at the back of the arm, and patients use a scanner or sometimes even their handheld phone and wave it over the sensor to get glucose levels on demand. What's been very exciting about both the continuous glucose monitors in real time and the flash glucose monitor here is that many of the newer versions don't require calibration with finger stick readings. So patients no longer have to prick their fingers anymore to check blood glucose. They can just get the glucose levels through the CGM. In addition, we have external insulin pumps often used for people with type 1 diabetes. As mentioned, they need to be on insulin therapy from diagnosis, or some people who are type 2 diabetes who also are on basal bolus insulin injections. It delivers insulin at pre-programmed rates from an external pump through a small catheter inserted under the skin. You can program the basal rates, for instance, 0.5 units per hour, 1 unit per hour. You can give more at times where the patient may be needing more insulin, give less at times where the patient may be less active, for instance, overnight. So it gives a lot more flexibility. And then patients can also bolus insulin. They give extra insulin when they eat, and they are given certain guidance, what we call the carbohydrate ratio. It's a ratio of how much insulin to give based on the number of carbohydrates they're eating. So for instance, 1 unit for every 10 grams of carbohydrates, and then a correctional scale, which gives an indication of how much insulin they should give for the blood glucose level, such as 1 unit for every 50 milligrams of deciliter glucose over a target, such as 150 milligrams per deciliter. So this is an example of an external insulin pump. And as you can see, this is in the abdomen, but it can really be worn at different sites depending on the patient's preference. And while that is called an open loop system, we have seen technology move closer and closer to what we call a closed loop, which is what we would really want in a true artificial pancreas. So some newer insulin pumps also have a continuous glucose monitor integrated into the insulin pump. So it sends glucose readings to the pump. The pump can then adjust the basal rates automatically, and then the glucose reading is read again, and then the basal rate is adjusted again as a closed loop to maintain the glucose levels at a target of, let's say, 120 milligram deciliter fasting. And so this is what we call a hybrid closed loop system. The first hybrid closed loop system was approved about 5 years ago. It was this Medtronic 670G. We now have 2 other hybrid closed loop systems available, the Tandem X2 with Control IQ and the Omnipod 5, which was just released a few months ago. And it's called hybrid closed loop because it still requires the patient to give themselves bolus insulin between meals. They still have to press a button to give themselves insulin before meals, but the basal insulin is automatically adjusted based on the glucose levels with the integrated CGM, which is really, really exciting. So in summary, there are currently more than a dozen classes of glucose lowering therapies for type 2 diabetes available on the market. There are oral therapies, injectable therapies, and inhaled versions. There are many considerations in choosing what medication to use for your patient, including the A1C lowering efficacy, effects on weight, cost, the frequency of dosing, the route, and the risk of hypoglycemia. And additional considerations might include whether they have comorbidities. And this has become more and more important, especially as we understand that many of these newer agents have cardiovascular benefits. So in those with a history of cardiovascular disease, you do preferentially want to include one of those agents that I mentioned from the GLP-1 receptor agonist or the SGLT2 inhibitor classes that have demonstrated cardiovascular benefit and an FDA indication for that benefit. And also in those with a history of heart failure, wanting to use one of those medications that have demonstrated benefit for those patients as well. Newer developments in diabetes technology have dramatically transformed the management of diabetes, and we will continue to see many updates in the future, which will facilitate even greater strides in management of diabetes for our patients. So with that, I will thank you for your attention.
Hi, Dr. Kalyani. How are you?
How are you, Brian?
Doing well, doing well. Thank you so much. That was a really fun and interesting presentation.
Thanks.
We do have a couple of questions from the audience, if you have a couple moments. I think one that was said a couple different ways was, why has the prevalence of diabetes been increasing over recent years?
That's such an important point, and I'm so glad you raised that question. We have seen diabetes increase in prevalence, especially since the 1980s, when the prevalence was more like 3 to 4% in the United States. And now it's up to 10 to 11%, more than 35 million people in the US with diabetes. And what we've seen at the same time is a rise in the prevalence of obesity, which we know is a major risk factor for type 2 diabetes and makes our bodies more resistant to insulin. And coupling that more with urbanization, less physical activity, higher processed food diet, all these factors contribute to the higher prevalence that we're seeing of diabetes. And it's expected to continue to grow without further intervention.
That's interesting. Now, you mentioned physical activity. So why is exercise so important when it comes to prevention of diabetes?
Lifestyle modification, what we call dietary management and also exercise, is so important at all stages of the disease. And the reason that it's so important is that exercise, independent of weight loss, has positive effects on the body. It can promote the loss of fat mass, which we know exacerbates insulin resistance, and it can increase muscle mass, which is the main site of glucose uptake in the postprandial state after eating. And so physical exercise in itself can have positive effects on body composition by decreasing fat and increasing muscle mass. If it additionally leads to weight loss, and we usually recommend about a 5% weight loss for most people with diabetes upon diagnosis, that can further really work together with the other pharmacological interventions that we have to promote longevity and reduce complications with diabetes.
Oh, that's interesting. Thank you. One of the questions that came through, why does not why does, but does everyone with pre-diabetes eventually develop diabetes?
Prediabetes is a condition of high risk. It denotes individuals who have risk factors that may put them at higher risk for developing diabetes long term. And I didn't talk too much about that in the webinar, so maybe I could just talk for a few minutes about prediabetes. So risk factors for prediabetes might include having a family history of diabetes, belonging to high-risk ethnicity, Asian, African American, Hispanic, or what we talked about with physical inactivity and dietary modifications as well. Women with gestational diabetes are at a higher risk of prediabetes too. And what we know is that the criteria to diagnose prediabetes, as I shared in one of the slides, is really the cutoffs are intermediate between normal and diabetes. And without intervention, many of those people will go on to develop diabetes. But we know from the Diabetes Prevention Program, which was a large study done in the United States that looked at the benefits of lifestyle changes, such as reducing calorie intake and exercise compared to a medication, metformin, and then compared to placebo, that those in the lifestyle arm had a 58% reduction in the onset of diabetes. And so that's why lifestyle interventions are so important for people with prediabetes to reduce the progression to diabetes. So to answer your question, not everyone develops diabetes. It can be delayed, and lifestyle interventions are critical to that happening.
That's great. That was a great question. That was a great answer. Thank you. Now, I know we have in the audience, we have people that are different physicians and pharmacists and nurses. In your experience, who are the usual members of a diabetes care team?
Diabetes really requires a comprehensive team approach, and any individual that sees, whether it's a primary care physician or an endocrinologist, really is also seen by many other members of the team. These include a dietitian, which really focuses on management of the diet and lifestyle modifications like we talked about. Often a nurse diabetes educator who can work with the patient on achieving self-management goals and further reinforce concepts that might be challenging to manage diabetes at home. A pharmacist might also be a member of the team, depending on the needs of the patient, to help with medication counseling and coverage. We know that unfortunately many of the newer medications are a bit more expensive, and sometimes there can be some restrictions on what's covered. And so we often rely on pharmacists for their expertise. And then in addition, we are now expanding our care to cardiologists because they are prescribing a lot of these medications as well for cardiovascular risk reduction, nephrologists who are also prescribing traditionally diabetes drugs for reduction of kidney disease, because we know that they have benefit there as well. And so now we're seeing more and more specialists being involved in a very direct way in prescribing glucose-lowering medications. And as a result, our care team continues to expand, and it's important that all members of the team are engaged in providing that patient-centered care.
That's great. Thank you. Last question, if you have another minute, just what would be your advice on telling a patient, like, why is self-monitoring blood glucose just so important?
You know, self-monitoring of blood glucose doesn't get talked about a lot. We talk a lot about continuous glucose monitoring, and the technologies are really exciting, but I think we need to remember that at its core, it's important for people to check their blood glucoses at home, whether it's with the newer technologies, whether it's with the home glucose meter, which has always kind of been the cornerstone of ensuring that any medication changes that are made safely. Patients can monitor their sugars at home and ensure that their sugars are not falling too low. Or if sugars are going high at home, really using that as a way to alert the healthcare team and discussing other therapies that might be needed to really attain glycemic targets. And so while hemoglobin A1C is something we talk about a lot, it's one number, it's an average over 3 months, and self-monitoring of blood glucose at home is really important for us to understand patterns during the day and where we can optimally intervene to really attain those glycemic targets.
Fantastic. Great. Well, any final moments, any final remarks on this World Diabetes Day, Dr. Kalyani, before we say goodbye?
Well, as you mentioned, Brian, this is really such an exciting time for people with diabetes, for those of us who care for people with diabetes. We've seen so many new therapies that have been approved and available for people with diabetes over recent years, so many new technologies as well. And as healthcare providers, it's really important for us to keep up with the latest developments in order to be able to provide the standard of care, the optimal care really for patients with diabetes. And so I, for one, am very excited for things to come and hope that we can continue to provide the best care possible for our people, for our patients with diabetes.
That's fantastic. Well, Dr. Kalyani, thank you so much. These updates in diabetes care is helpful to so many. And to our attendees, we will be sending out a recording of this to everyone that attended. And if you have any questions, feel free to reach out to webinars@unboundmedicine.com. So again, thank you very much, and I hope you all enjoy your day.
Thanks.
Thank you.